Hi, this is Lisa Amaya Jackson, and I am pleased to introduce this podcast series. Our Category 2 sites have been discussing evidence-based treatment within an evidence-based practice approach, and while we have many EBTs we are proud of in our network, we wanted to take advantage of the fact that we can hear from a pioneering expert researcher in the field of traumatic stress on the evidence-based treatment she developed called cognitive processing therapy. Dr. Resick will share from not only what is the evidence for this treatment, but from the black box of how the use of research data informs the EBT and the shaping of its key elements and application so that it is translated into the best treatment for those clients that are seeking help for the target symptoms. Cognitive processing therapy is an adult treatment, and its application to the NCTSN is not just to learn from research and science, but also that it's a treatment that is being used in the NCTSN when we see a parent's need for treatment intervention as we work with them and their children. So first of all, thank you all for joining us. I'm going to introduce Dr. Patty Resick, and then I want to talk to you about the series and the Q&A that we're going to be doing today. Dr. Resick is currently a professor in the Department of Psychiatry and Behavioral Sciences here at Duke University. She has worked in a number of places and has held an endowed professorship, and she has been continuously funded for more than 40 years, receiving grants from NIH, NIJ, Centers for Disease Control, SAMHSA, the VA, and the DoD. Patty said for her that she didn't want me to do too many accolades, and people are very familiar with Patty, but I did want to emphasize she is the developer of cognitive processing therapy. She has published 9 books and over 300 journal articles and book chapters. She's been on many editorial boards, and she is actually going to be presenting on a keynote next week at ISTSS, where she has served as a Secretary, Vice President, and President of the International Society for Traumatic Stress Studies. As I have mentioned in regards to the fact that we have had a podcast series that I'm going to show you the specific videos on, where we were talking about the iterative research evidence that shapes clinical content and application of evidence-based treatment, we had asked Dr. Resick, who is a pioneering expert researcher in the field of child traumatic stress on cognitive processing therapy, to share with us not just the evidence base for cognitive processing therapy, but also the black box of how we use research data to inform evidence-based treatment, the shaping of its key elements, and its application so that it's translated into the best treatment for those clients that are seeking help for the target symptoms. Cognitive processing therapy is indeed an adult treatment, but has also been used with adolescents, and its application to the NCTSN is not just to learn from research and science, but also that it's a treatment that's been used in the NCTSN when we see a parent's need for treatment intervention as we were working with them and their children. So why don't we begin? We have a series of 5 podcasts that I'm going to show in the next slide that have lasted about 20 to 30 minutes on these topics right here, exactly. And these are: what is cognitive processing therapy, development and early research? Who else does CPT work for? The third one is on changes in PTSD diagnosis and treatment conceptualization. The fourth is on a change in style and theory. And 5 is on dissemination of CPT and what we have learned. And you can see the link right there, and these are all individual podcasts that can be listened to separately. The next slide. So what we're going to do today is we have pulled together questions from NCTSN centers, and we're going to list them on the following slides under their respective topic headings. There'll be times where we're going to pause, actually 3 times, to see if participants have additional questions to the ones that we've pulled together here that they would like to ask Dr. Resick. And you will see in the bottom right corner of select slides an icon showing where we will take questions. So why don't we get started? So the first one is under the heading of ensuring CPT is responsive to the evidence. Let's take the first question, Patty. Your work to ensure CPT was responsive to the scientific evidence is an important part of the evidence-based practice approach. Could you share from your perspective the importance of using an evidence-based practice approach in the trauma field?
Yeah, I think it's not just the trauma field. I think it's any field of psychology or psychiatry where you're trying to determine whether something works. I think we have to not be shy about evaluating how our clients are doing every step of the way, because if they're not getting better, we need to know why. Are we going down the wrong path with them? Are they talking about a lesser trauma because they don't want to talk about a worse trauma? Is there a stuck point, a thought that they have that's keeping them stuck in their PTSD that they don't want to deal with? Those kinds of things. But you're not going to know if they're not improving if you don't assess them regularly.
Great.
So we use self-report measures that are fairly short. They can be done in 5 minutes before the therapy session starts, and then we can track. And I think then over the bigger picture with doing the big studies, then do these studies work with whole groups of people, and who do they work for, who don't they work for, can we improve the therapies and so forth.
All right, thank you. Thank you. What were the places in the evolution of CPT where the research funding may have caused you to change course or influence changes in the model? And I'll also ask, what do you think was the most impactful change to CPT based on the subsequent trials?
I'm not sure it was that the research funding necessarily changed it, but I did have different questions along the way. I mean, in the beginning, I developed CPT and then tested it with an open trial because I didn't have any funding, and I was doing group treatment because I thought that's what rape crisis counselors might be using, as well as the fact that I could collect more data without any money if I'm doing groups. But later then I wanted to do a good, well-controlled, randomized control trial, and that's when I compared it to prolonged exposure, which had come out just before this did, and was the best other therapy at the time, and then a waiting list control group, of course, just see if time alone would have fixed it. So the biggest change, I think, happened between study 1 and study 2. I don't think we changed a whole lot. We just found out that CPT, in fact, did work. I think it was billed as being a therapy for rape victims, but I think the first thing we learned was that there's no such thing as just a rape victim. 84% of the women had other interpersonal traumas happen to them: child sexual abuse, domestic violence, attempted murder, all sorts of things. So most people who come to therapy have a very complex trauma history, and so that's who we were treating right from the beginning. The next biggest change happened was because after I did that study, the theories that were extant at the time were still saying that, well, it's got to be the exposure piece. You're having them write an account. That must be the active thing. And what are you doing all that cognitive therapy for? So then I did a dismantling study because there were a number of additive studies going on at the time. Like, if you could do exposure, does adding this or adding that actually make the therapy better? But you would need a massively large sample to actually find some differences. So I was in the position where I could do a dismantling study and take out a component, and so I had full CPT with the written accounts. I had CPT without written accounts, and then I had written accounts only. And that probably was one of my biggest shifts because I was surprised to learn that the written accounts didn't have any added value. They didn't do any better in the end, and they had a 15% higher dropout rate. And in fact, the people who didn't do the written accounts were showing faster recovery. So when we were talking to military people who were actually going to Iraq and Afghanistan to do treatment, if you only had 5 sessions, what are you going to do? You would do CPT without the accounts.
Right. Wow. I think we have some additional questions where we tease that apart a little bit, and I bet there will be some interesting questions coming from the audience as we talk about it in relation to children. Thank you for that. So as you just mentioned, one of your major research initiatives was the comparison of the 2 active trauma treatments and CPT. What was it that facilitated that project? How did you, come to decide to do that project?
In graduate school, I was in a program where we were taught how to do clinical research, and that was the thing I was most interested in, is developing therapies and testing them to see if they worked and who they worked with. And And so, I mean, I wrote a grant application. It took me a while to get it, actually. I got an assessment study first, and then it took me 84 pilot cases before I actually got a big grant to compare it with prolonged exposure. But we wanted all the bells and whistles so that we could say it's the therapy. It's not just time alone. It's got good fidelity. We've got blinded raters who don't know which therapy the people are getting. So we wanted to get all the biases out of there and have some assurance that we could say that this therapy was actually working.
That's great. Can you share some of the findings? I know that we have the videos, so I was wondering if you could share some of the findings with the group here.
Well, we found, first of all, that CPT and PE worked equally well for PTSD and depression. But we learned also that when it came to some of the secondary symptoms like guilt, hopelessness, suicidal ideation, some of those more cognitive kinds of symptoms actually did better with CPT, which makes sense because it's cognitive therapy.
Exactly.
And those lasted. I mean, some of those findings lasted for the 5 to 10 year follow-up we did later.
Thanks. Would you say the level of funding and resources necessary to pull two active, to do a study that compares two active treatments are different than some of the other studies you've done?
Well, we're past the point of doing waitlist controls, at least for my therapy, because I mean, I think for any PTSD study, I don't think you can do a waitlist control or just say no treatment control, because to me now that would be unethical. We have therapies that work. So I think you have to do a head-to-head study.
Right.
And sometimes now I'm just comparing CPT this way versus CPT that way. So I'm not even necessarily comparing it to another therapy.
Is it more expensive given you have to have have the power to detect a difference between something that works and something that works?
Yes, it is more expensive, and I think you have to kind of work your way up to being able to do a big trial or link up with a senior researcher who has the clout to get a bigger trial. Now, back when I started 30 years ago, it was easier to get grants than it is now, and with some of the limitations, unless you have a salary, it's very hard, unless a number of the people on the grant have salaries. Like in the VA, we could do studies with not as much money because we had salaries. But if you're in a place where you're having to pay people salaries to do the studies, then it becomes very expensive.
Right, very much so.
Millions of dollars.
Looking at question number 4, we touched on it earlier. I don't know if you wanted to add anything about how you see the role of evidence-based practice in the trauma field evolving over time. Kind of touched on it, you feel like, particularly for yours, that just waitlist controls, are, we're beyond that. I know a number of our treatment developers in the NCTSN have used active controls, but not necessarily head-to-heads with two other well-known trauma treatments.
Right. Well, that's a step in the right direction, because I think what we're finding is that they developed, in one of the big VA trials, they developed what they call presence-centered therapy, and that was supposed to be a control. But what they found was that it actually had a pretty good effect, and so they needed a bigger sample than they thought they needed. So sometimes even just coming in to therapy has an effect. And that's why a lot of people think, well, what I'm doing is good enough because my clients are getting better, but what they may be showing is the nonspecific effects of just coming to therapy. You're getting in your car, you're driving to the therapist, you're thinking about yourself for an hour, you're talking to somebody who's a sympathetic listener. When else in your life do you do that?
Right.
So that is itself going to have an effect, and what we have to do then is say, does this therapy go above and beyond that? Is there value added by doing this specific therapy? So there's nothing wrong with doing those. We just have to take that step beyond and say, is there something added by doing this evidence-based treatment? Otherwise, you'd just be doing, talking to them for an hour.
Okay, let's move on to the next slide. So in terms of the components of CPT, you had mentioned that you had done the dismantling study. Can you tell us a little bit about that, your approach to it, and maybe the findings and what changed? You did a little bit of that already.
Yeah, I have. Basically, I told you the rationale for doing it was because I wanted to see if we really needed the cognitive component, if we needed the written therapy component, if they were both, and my theory was that we needed both, or otherwise I wouldn't have put them in there. So that was my hypothesis, that we needed both. But the other comparisons were to do cognitive therapy without the written accounts, and so we had to add 2 sessions to make it long enough. And so we had ABC sheets for another session, more Socratic questioning by the therapist, and then at a later point in therapy when we introduced the challenging beliefs worksheet, we just did that on their traumatic event before we moved on to some of our modules. So it was the same length. The hardest component to do was the written accounts component, because you couldn't just do 2 sessions. I needed to have it be 12 hours of therapy contact time, so we had to expand it. It looked a little bit more like PE, where we had 2 one-hour sessions, and then they would come in, they would show us their homework and, you know, what they had read or what their SUDS ratings were that week, you know, their units of distress, and then we'd put them in a room and they would write for an hour, and then they would come out and they would read it to the therapist just like they would do in PE, and then the therapist could react, but they couldn't do any cognitive therapy. So they had to do more like encouragers to speak, Rogerian kind of stuff. How did you feel? Did you leave anything out? I noticed you skipped over this part. Right. Can you write more on that next time? So we had to try to equate them for time, and so that's where we had to make some adjustments or, you know, around it to actually test 3 therapies and make them kind of equal time.
Exactly. I know you and I have talked at times about these study results, and, you know, in particular some thoughts about, you know, why would we find that different, or would we find that different in our child work? Why could you maybe recall for the group some of, you know, the basis for what you thought was the answer to that question of why is CPT without the written account something that would work in adults but may not be the best strategy until further research comes in about it with children?
Yeah, and I think it's a good question whether it works better with children, because I don't think that's been studied yet, has it?
Well, TFCBT has done some stuff with
and without.
With and without.
Okay. All right. Well, I think that we did find one group that they did better with the written accounts, and those were the high dissociators, and that was because their memory was encoded in fragments. And so they're the only group that really did, and even low and medium dissociators did fine and did better actually with CPT without the accounts. But the high dissociators needed to put the story back together before you could do the cognitive work. Right. Okay? Now, why did the rest of them do better without the accounts? I think because when you just ask somebody to write an account, they're not necessarily writing about what got them stuck in their PTSD. It's all my fault. I should have done something different. If only I had done this, because they're just giving you the facts about what happened. And they may be leaving out some of the worst stuff, or the reason, you know, like why they're blaming themselves. They may be focusing on the gory details, but that may be irrelevant to why they had PTSD. So they may be skipping over some of the important things. We're not telling them, write this, write this, write this, write this. Right. So maybe in child it's a little bit more structured way of doing it, but with adults we were just saying write your account.
Right. I think the other thing we had talked about at one point was the amount of fear and danger, and that for children at their level of development, of helping them to acknowledge that and to be able to habituate some of the anxiety and the fear that was just so present. Was just a critical element that we've held dear in the child trauma world, and then of course the cognitive processing that's part of the trauma narration process in many of the works in the NCTSN deals with some of what you're saying as well. But I think I remember us having some conversations about the incredible fear piece that children experience and need to be able to habituate to before we would start in with the cognitions and helping them to kind of go through those pieces.
Right. And with adults, it may not be as much about the fear as it may be about their guilt, their shame, the betrayal. Of course, they're thinking in more sophisticated ways, but they're also blaming themselves. and going back to try to undo the event in certain ways. It may be anger at the wrong person, too. Somebody may be angry at somebody who is in proximity rather than the person who actually caused the event.
So these sets of questions talk about changes in the delivery of CPT, and we're going to have another slide that talks about the adapting of CPT and disseminating CPT. So for this slide, we're going to be asking these two questions. I'll begin with the first one. When you're assessing a client's progress during a flexible administration of CPT, how is the a priori end state determined?
It's a good question. That was the other major shift, I think, that happened with CPT, and it wasn't mine, it was Tara Golofsky's suggestion to study variable length CPT. She totally changed the concept of what a treatment completer is. Instead of saying it's somebody who's finished 12 sessions, she was saying it's somebody who's gotten to a good end state. And a good end state isn't just that they don't have PTSD, but that they have low scores on PTSD and depression. And so some people were ending very quickly. In fact, in her study with adults, and they were both men and women, who had interpersonal traumas happen to them, 58% didn't even need 12 sessions. 26% needed, and she'd let them have up to 18 sessions. There were only a couple who actually stopped right at 12, and then there were a few that didn't. It's not to say they didn't improve, but they didn't get to that really low score, that good end state by the end of the 18 sessions. So it's totally redefining your endpoint. It's saying having a good outcome, whether it's shorter or longer. And one of the things we have found even with our dropouts is that there's a certain proportion, at least a quarter of our dropouts from therapy studies who are actually doing well. They just don't care we're doing research.
Exactly. And I think that speaks to what more and more approaches to both individual treatment and group treatments are around the importance of measurement-based care, you know, in daily practice.
Right.
And that fits with what you found in your research. What factors, if any, would you say contribute to a client requiring the greater or fewer sessions to reduce their PTSD symptoms?
I think in Tara's study, the depression seemed to be the big one. And we just finished a variable length study with active duty military, and we did not get 58% in less than 12 sessions. Military are much tougher to treat than civilians, as are veterans. Civilians aren't taught over and over and over again to think in certain ways, and the military are taught to think in certain ways. And so they're actually sometimes even taught stuck points. You know, they're taught, you know, it's all my fault, I'm responsible, no matter what happens. They'll say, I know I couldn't have stopped it, but I'm still responsible. So sometimes they'll dig their heels in on that kind of stuff. But anyway, we did a variable length study with them, and the same thing came up. We found out that the people who had the worst depression took the longest. And in military samples, I've gotten very interested in the death, the fact that so many of them have had friends die, have witnessed death, have had to clean up after death, and that sometimes the depression is not depression per se, but it's also complex grief responses. So I think we have focused a lot more in recent studies on really helping them come to grips with their grief, because instead they'll get angry, or they'll drink, or they'll do whatever it is they have to do to avoid and not think about it. But that turns out to be a predictor. This last study that we did with the military, we also found out that on the readiness to change scale, that the ones who didn't change over time or didn't change as much as the ones who got to a good end state were still in pre-contemplation stage. So that would be something to give somebody before you even start treatment with them, because if they're not ready to actually start treatment, they're probably not going to get as much out of it.
Thank you. Next slide. So in issues around adapting CPT, you had made mention of the fact that in that one study that you were finding the folks who needed the written account tended to be those who were dissociating. This question is asking why do you think the written account specifically aids the recovery of those clients?
Well, as I said, I think what happens is when you dissociate during an event, that peri-traumatic dissociation, everything's coming in little bits and fragments, and part of the time you're not there, you may not remember certain things. And by writing the account, you're putting a beginning, a middle, and an end to it. And then you can actually start saying, okay, now what does it mean to you that this happened?
The structure.
Yeah, so it brings a structure back to it so that you can actually work with it, because otherwise it's just a bunch of flashes that they have in random order.
Thank you. Do you plan to evaluate additional components of CPT and their impact on specific symptomatology presentation?
Currently, we are not looking at components per se, but we are, there have been a couple of studies, and now it's starting to move away. Other people are doing all sorts of things. Tara first introduced the concept of having stressor sessions. She allowed 2 stressor sessions during variable length CPT. And by that I mean that something really horrible happened in their life. Somebody died, they got a cancer diagnosis, they lost their job, they suddenly became homeless. In other words, like, just couldn't do CPT that day. And they only gave them 2 of those sessions, but they'd say, do you want to stick with the protocol or do you want to take a stressor session? And I think you know, like maybe 13 of them used a stressor session. They mostly held them in the bank. And I think that's really good if they've got borderline type symptoms, because if you gave them an unlimited number, they would use them weekly. But when they only have 2, they're going to hold them and say something more serious could come along. And so that was one thing that they did. And then and now they're testing kind of a case formulation addition to CPT. So if somebody has something that's really interfering and they're looking at their scores and they're not coming down, if they've done a good case formulation with them at the beginning of therapy, do they have a substance abuse problem? Is that interfering with their treatment? Do they have an eating disorder? Or are they cutting? Or, you know, it's like, or things like that. Do they need to stop the protocol, do up to 5 sessions of something else, not CPT, and then move back to CPT? Now, the trick is getting waylaid and never getting back to the CPT. That's why they've limited it to 5 sessions of doing something else, like sleep treatment or whatever.
Right.
So they're now testing that, and in the pilot that they did, about half of them didn't need any kind of modification to the treatment. The other half did need some kind of intervention to help them get over some hump that they had with other comorbid kinds of symptoms. Right. So that's one thing. The other thing that's happening now is that people are working on shorter and shorter versions of CPT. Mostly it's been pilot work. We have one study now that's actually looking at CPT in a week, as opposed to 6 weeks.
Wow.
Twice a week for 6 weeks versus every day for a week. And we're thinking that's really going to help with the dropout rates, because the ones that have done anywhere from 1 to 3 weeks have had much lower dropout rates than the ones that drag on like once a week or even twice a week, because we find the fewer the number of days between sessions, the better the outcome. So if we can do the therapy faster.
So I remember the NPR article. Was it from This American Life?
Yeah, it's a podcast. Yes, and it's This American Life. It's called 10 Sessions. And what happened was that a reporter approached Deborah Kaysen, one of my colleagues out in Washington. She was in, I think, New York, and flew out there for 2 weeks and said, can you do CPT in 10 days? And they recorded it, and they got it down to, of course, you're hearing bits and pieces of the therapy, but it's interesting because it's not very often you get to be in the therapy room and hear what it sounds like, and also hear her perspective on it. And so it's good for therapists to listen to, because they actually get to hear what the client is thinking.
Right.
I think at one point she said that the form looked like something you get from the DMV.
I remember that. I commented on it because I had thought that the doing it all in a week or two, it was a short 2-week time period, was something just because it was for the sake of the story. But it sounds like you're actually conducting CPT in these shorter time frames and evaluating that.
Right. Rush Hospital in Chicago has a big program where they're doing it in 3 weeks, but they have all sorts of stuff they were supposed to add to it, but when they did a survey, it was the CPT that was the most helpful. But yeah, out in Utah, they're doing a 2-week version with, and it tends to be for military, like special forces people, and they'll bring their family out on vacation for 2 weeks if they don't want anybody to know they're getting treatment because they don't want to lose their security clearances. So they'll do CPT every morning, and then they'll go hiking or skiing with their families in the afternoon. And they're getting very good results in 2 weeks.
Amazing. So you see there's an icon break for questions. It looks like we have one that's come into the chat box. Someone's making the point, in CPT we usually have the child write the play-by-play details of the events themselves, but also have them affect on their subjective experiences and responses. I think that was based on our earlier conversation. Thank you for that comment.
The second part of that question from Dan Hoffman is, so to clarify, the narrative in CPT is details, not responses?
The narrative in CPT was asking them to give sensory details from the time you knew you were in danger till the time it ended. So yeah, they were asking about responses. What were you thinking? What were they saying? What were you saying? You know, like whatever they decided to put into the account. But it was, you know, we had some people would, I remember we had one World War II veteran who started his account at the beginning of World War II. That's a little too far out. Could we start when the kamikaze was about to hit the ship, you know, and you saw him coming in? So we had to, you know, we had to help people say from the time you knew you were in danger until the event stopped. And what we found sometimes is the event didn't stop when we thought it stopped, you know. 14-year-old who we happened to treat was abducted and raped, and when she came back home, her father, she only had a father, he beat her up for having been raped. And that was just as traumatic as the rape.
Wow.
So she just mentioned it in the first time she wrote the account, and we wouldn't have known about that. But the second account she wrote, we said, okay, spend a little less time on the rape, spend even more time on what your dad did. And that's where an awful lot of her stuck points were. And he wouldn't go to the trial and all these things. So.
Thank you.